Welcome to the Deep Dive, your shortcut to becoming truly well-informed, fast, in a world, well, drowning in health information, especially complex stuff like cardiovascular health. Finding clear, actionable insights can feel like searching for a needle in a haystack.
It really can. And that's exactly our mission today. We're doing a deep dive into a really comprehensive source on cardiovascular health. We're going to try and demystify hypertension, dyslipidemia, and heart failure.
Okay.
The goal is really to pull out those key nuggets of knowledge, maybe some surprising fact, those aha moments,
Yeah.
to help you truly understand these vital topics without feeling completely overwhelmed.
Decoding your heart's blueprint, I think you called it before. I like that.
Yeah, something like that.
So let's jump right in. Hypertension, often called the silent force.
It really is silent, often. At its core, hypertension, high blood pressure. It's not just a number. It's actually a complex disease. The root cause is often vascular dysfunction.
Meaning the blood vessels.
Exactly. They aren't working as smoothly, maybe not as flexibly as they should. And when those vessels are under constant high pressure, it leads directly to what we call target organ damage, or TOD.
Ah, okay. Damage to vital organs.
Precisely. Brain, heart, kidneys, eyes. And the key insight here, really, is that getting your blood pressure down to the evidence-based goals, that's absolutely crucial to protect those organs.
So how does blood pressure actually, work? I seem to remember a basic formula. Can you break that down?
Absolutely. It's fundamentally pretty straightforward, though the system is complex. It's blood pressure equals heart rate times stroke volume times peripheral vascular resistance.
Okay, let's unpack that slightly. Heart rate is obvious.
Yeah, how fast the heart beats. Stroke volume is how much blood it pumps out with each beat.
Got it.
And peripheral vascular resistance, well, that's how much resistance or sort of tightness there is in your blood vessels that blood has to push against.
Right. So if any of those go up.
BP goes up if your heart beats faster or pumps more blood per beat, or if your vessels tighten up, blood pressure rises.
And the opposite is true, too.
Exactly. Decrease any or all of them, and pressure falls.
Yeah.
It helps understand where treatments are targeted,
That does clarify things. But, okay, if it's left uncontrolled, what kind of serious damage are we talking about, those target organs?
Yeah, the damage can be quite severe. That's why managing it is so critical. For the brain, uncontrolled hypertension significantly bumps up the risk for stroke, and also for vascular dementia, which is, thinking problems caused by damage to the brain's blood vessels.
Okay. Serious cognitive impact there.
Definitely. Then, in the cardiovascular system itself, it speeds up atherosclerosis, that hardening and narrowing of the arteries.
Which leads to heart attacks.
Correct. Or it can cause the heart's main pumping chamber, the left ventricle, to thicken up. That's called left ventricular hypertrophy, or LVH. Makes the heart less efficient and eventually can lead to heart failure.
And the kidneys.
Kidneys take a big hit, too. Hypertensive nephropathy, we call it. It can progress all the way to kidney failure, needing dialysis.
Wow.
And let's not forget the eyes. Hypertensive retinopathy. Damage to the blood vessels in the back of the eye, which can, unfortunately, lead to vision problems, even blindness in severe cases.
Hypertensive retinopathy. That sounds particularly alarming. Tell me more about that. What does it actually mean for vision, and how serious is it?
It's a really powerful, visible sign of how severe the hypertension is. The milder forms, grades 1 and 2, you might see just some subtle narrowing of the tiny blood vessels in the retina, often seen with long-term, maybe poorly controlled BP, usually reversible.
Okay, but the higher grades.
That's where it gets really serious. Grade 3 and grade 4. They often signal a hypertensive emergency. Grade 3, you might see tiny hemorrhages, little spots of bleeding in the eye, often seen when the diastolic pressure, the bottom number, is like 110 or higher. Potential vision changes there.
And grade 4.
Even worse, usually diastolic over 130. You see swelling of the optic nerve head, called papedema. Both grade 3 and 4 mean there's an acute threat to vision, potential for permanent damage, a major red flag. The eyes are literally showing us the severity.
The eye is a window.
Right.
Incredible. Now, when it comes to actually treating hypertension, it seems like there can be different guidelines out there, JNC8, AOACC. How do clinicians navigate that? What should we know about the goals?
Yeah, that's a key point, and there's been some evolution.
Right.
We often compare JNC8 and the more recent AACC guidelines. The main difference is the target BP goal.
Right.
JNC8 generally aims for less than 410/90 for most folks, but the AACC guidelines, they set a more aggressive target, less than 33/80 for pretty much all adults.
Why the change to a lower target?
It reflects a growing body of evidence showing that even blood pressure in that, 130/440 range carries significant long-term risks for heart attack, stroke, kidney disease. So stricter control offers better long-term protection.
And does that 130/80 target apply even if someone has, say, diabetes or kidney disease?
Yes, that's another key point from the AACC guidelines. They apply that 3D80 goal broadly, including those with diabetes, chronic kidney disease, heart failure history, because those groups benefit significantly from tighter control in terms of reducing future events.
Okay, that makes sense. So what are the go-to medications, the first lines of defense?
When lifestyle changes aren't enough, we look at first-line agents. Typically, it's one of four main classes. A thiazide diuretic.
Helps get rid of salt and water.
Exactly. Or a calcium channel blocker, or CCB, which relaxes blood vessels. Or an ACE inhibitor, often ending in trill, or an ARB, ending in sartan. Those also relax blood vessels, but through a different mechanism, blocking certain hormones.
Are there specific recommendations for certain groups?
Yes, there are some important nuances. For Black adults, the guidelines often specifically recommend starting with either a thiazide diuretic or a CCB.
Why is that?
Research suggests these tend to be more effective in this population, likely due to some underlying physiological differences in how blood pressure is regulated. Also, if someone has chronic kidney disease, CKD, an ACE inhibitor or an ARB is generally the preferred first choice.
Ah, because they protect the kidneys.
Precisely. They offer kidney protection that goes beyond just lowering the blood pressure itself. Very important benefit there.
That really clarifies the why behind those choices. So if someone gets a new diagnosis of hypertension, what happens next? What tests are usually run?
Right. It's not just about confirming the high reading. There's a standard workup. We do several essential tests to get the full picture of their cardiovascular health.
What are the main goals of those tests?
Really, threefold. 1, build a complete cardiovascular disease risk profile. 2, establish baseline values before starting meds, things like kidney function, electrolytes. And 3, super important, screen for any secondary causes.
Secondary causes, like something else causing the high blood pressure.
Exactly. Could it be underlying kidney disease? A thyroid problem? Even sleep apnea? So we check things like fasting blood glucose for diabetes, a lipid panel for cholesterol, serum creatinine, and EGFR for kidney function, electrolytes, TSH for thyroid.
Okay.
Also, a urinalysis to check for protein in the urine, and usually an electrocardiogram and ECG to look at the heart's electrical activity and structure. It's about seeing the whole picture.
A truly thorough workup. Let's dig into those priority medications a bit more. What are some key things to know about common side effects or special considerations? Let's start with the diuretics.
Okay, thiazide diuretics.
Yeah.
As we said, they help shed sodium in water, so they can lower your sodium, potassium, and magnesium levels that needs monitoring. But interestingly, they are calcium sparing.
Calcium sparing.
Yeah, they help the body hold on to calcium. And there's actually some data suggesting lower rates of bone fractures in women who use them long term. Kind of an interesting side benefit.
Huh, interesting. Okay, what about ACE inhibitors and ARBs? The prols and sartans.
Right, ACE inhibitors and ARBs. Great drugs for relaxing blood vessels. Now, they are potassium sparing, the opposite of thiazides.
Meaning potassium levels can go up?
Correct. Risk of hyperkalemia, high potassium.
Yeah.
So we watch that, especially if kidney function isn't perfect or if they're combined with other potassium-sparing drugs. ACE inhibitors specifically are known for causing a persistent dry cough in some people.
Ah, yes, the ACE cough.
That's the one. If that happens, switching to an ARB usually solves it, as ARBs don't typically cause that cough. Another, much rarer but serious side effect of ACEs is angioedema, sudden swelling, often around the face, lips, tongue.
Scary. Who's at higher risk for that?
It's more common in individuals of African or Latino ancestry and maybe those with a history of allergies to NSAIDs. And crucially, both ACE inhibitors and ARBs are absolutely contraindicated in pregnancy. Category D, big risk to the developing fetus.
Got it. No pregnancy use. But you mentioned ACEs are good for diabetics.
Yes, ACE inhibitors are often considered a priority choice for people with diabetes, again, because of that added kidney protection they offer.
Yes, makes sense. And calcium channel blockers, CCBs.
Okay, calcium channel blockers. One common side effect, especially with the dihydropyridine type like amlodipine, is ankle edema, or swelling. Tends to be dose-dependent, worse at higher doses.
Right.
Also need to use them with caution, or sometimes avoid them altogether in certain types of heart failure, or if someone has significant kidney or liver problems.
What about other meds like beta blockers? Are they still used?
Yeah, beta blockers like metoprolol, atenolol, they're not typically first line just for hypertension anymore. Their BP lowering effect can be a bit less predictable, especially in older adults. And you need caution with them in people with lung issues like asthma or COPD, as they can potentially worsen breathing.
Okay. And aldosterone antagonists.
Like spironolactone. These are also potassium sparing, so same risk of high potassium, especially if used with an ACE or ARB. A unique side effect, particularly with longer-term use of spironolactone, can be gynecomastia, breast tissue enlargement in men.
Good to know. This brings us to something really critical and often confusing. When is super high blood pressure truly an emergency? What's the difference between hypertensive urgency and hypertensive emergency?
This distinction is absolutely vital. Both involve severely high BP, usually defined as over 180 for the top number or over 120 for the bottom number. But the key difference is the presence or absence of acute target organ damage.
Okay, so break down hypertensive urgency first.
Hypertensive urgency. BP is sky high, but, and this is the crucial part, the patient is stable. They have no acute or impending signs of organ damage. No new chest pain, no sudden vision loss, no stroke symptoms, no acute shortness of breath indicating heart failure.
So the number is alarming, but the person seems okay.
Pretty much. They might have a headache, maybe feel a bit anxious, but no evidence of acute organ damage happening right now. The intervention here is typically to restart or adjust their usual oral blood pressure meds. Importantly, there's no need for immediate, rapid BP lowering in the office with fast-acting drugs. And, crucially, no referral to the ER or hospitalization is generally needed. The goal is a gradual reduction over hours to days.
Okay, gradual reduction, no ER rush. Now contrast that with hypertensive emergency.
Hypertensive emergency. Fundamentally different, same high BP. But here the patient does have clear evidence of new, impending, or progressive target organ dysfunction.
Like what kind of evidence?
We're talking about signs like acute heart failure symptoms, severe shortness of breath, maybe pulmonary edema, fluid in the lungs, or acute kidney injury, or neurological signs like confusion, seizure, stroke symptoms, or intracerebral hemorrhage, or that severe hypertensive retinopathy we talked about, grades 3 or 4, indicating acute damage in the eye, or even aortic dissection.
So actual organ damage happening now.
Yes, this is a true medical emergency. The intervention is immediate transfer from primary care to a higher level of care, usually the emergency department, often leading to an ICU admission. The goal is controlled BP reduction using intravenous medications. It needs to be done carefully, not too fast, but promptly to limit further organ damage.
Can you maybe illustrate that with a quick example?
Sure. Let's imagine two patients, Joseph and Samuel. Both 68, long history of hypertension, stopped their meds 3 months ago. Both present with a BP of 210 over 122.
Okay, same starting point.
Joseph says he feels fine. Denies chest pain, shortness of breath, vision changes. His exam is normal except for the BP and maybe some mild grade 1 retinopathy changes he's had for years. Joseph is in hypertensive urgency. We'd restart his oral meds, maybe add another, and arrange close outpatient follow-up.
Right, now Samuel.
Samuel comes in saying he's had worsening vision and shortness of breath for 3 days. On exam, he has grade 3 hypertensive retinopathy, those hemorrhages. You hear an S3 heart sound. His neck veins are distended, and you hear crackles in his lungs. His heart rate is 120. Samuel is in hypertensive emergency. He has acute target organ damage, the eyes, the heart, the lungs. He needs immediate transfer to the hospital for FEV treatment.
That comparison makes the difference crystal clear. Thank you. Let's shift gears now to dyslipidemia, managing cholesterol and triglycerides. Who needs screening for this?
Screening with a lipoprotein profile that's like total cholesterol, LDL-C, the bad cholesterol, HDL-C, the good cholesterol, and triglycerides is really important for anyone with significant cardiovascular risk factors.
Right.
People with diabetes, existing hypertension, anyone with a strong family history of early heart disease or high cholesterol, people with obesity. Basically, understanding these lipid numbers helps us gauge your future risk for heart disease.
Does the test need to be fasting?
It can be done non-fasting for initial screening. But if the triglycerides come back really high, say 400 milli-GDL or more, then a repeat fasting test is definitely recommended for a more accurate triglyceride level, as recent meals can really affect that number.
Makes sense. When we talk treatment, statins always come up first. Why are they considered the leader, and what are the different intensities?
Statins are absolutely the evidence-based leader. They're incredibly effective at lowering LDL-C, primarily by blocking a key enzyme in the liver that makes cholesterol. We categorize them based on how much LDL reduction they provide.
Okay.
High-intensity statins like higher doses of atorvastatin or rosuvastatin aim for a 50% or greater drop in LDL. Very potent. Moderate intensity, like lower doses of those, or drugs like simvastatin, pravastatin aim for a 30% to 49% reduction. And low intensity gives less than 30% reduction, which isn't usually enough for most people needing treatment, so it's not often a first choice. The intensity is matched to the patient's risk level.
Are there situations where high intensity might be avoided?
Yes, sometimes caution is needed, for instance, in individuals over 75, or those with impaired kidney function, significant frailty, multiple other health issues, or if they're taking certain other drugs like fibrates, we might opt for moderate intensity even if their risk is high, just to minimize potential side effects.
Speaking of side effects, what are the key things to know about taking statins? Any common misconceptions?
Well, one big one is liver enzyme monitoring. We check liver enzymes before starting to get a baseline. But routine monitoring after starting generally isn't needed unless the person develops symptoms suggesting a liver problem. That's a change from older practice and a common point of confusion.
Good to clarify. What about interactions?
The main one people hear about is grapefruit juice. It can interfere with the metabolism of some statins, specifically simvastatin, atorvastatin, and lovastatin, potentially increasing drug levels and side effect risk. So caution is advised there.
And muscle issues.
Right? Muscle pain or weakness can occur. It's usually mild, but needs checking out. Very rarely, it can progress to something more serious called rhabdomyolysis, which is muscle breakdown. This is more likely with higher doses, certain drug interactions, or in people with specific risk factors, but it is quite rare overall.
Beyond statins, what other options are there for people who need more LDL lowering or maybe can't tolerate statins?
There are several other good options now. Ezetimibe is an oral medication that works differently, blocking cholesterol absorption from the gut. It can add another 15–20% LDL reduction, often used in combination with a statin or if statins aren't tolerated.
Okay. What about injectables?
Yes, we have PCSK9 inhibitors. These are powerful injectable drugs usually given every 2 or 4 weeks. They work on a specific protein involved in clearing LDL from the blood and can lower LDL by a whopping 60% or even more. Often used for very high-risk patients or those with familial hypercholesterolemia who aren't at goal on maximum statin therapy.
Any other?
There's inclisiran, another injectable, but it works differently using RNA interference technology. Also gives very significant LDL reduction, but dosed less frequently, maybe every 6 months after initial doses. For people who truly can't tolerate statins due to muscle side effects, there's bempedoic acid, an oral drug that can lower LDL by up to 33%.
What about managing triglycerides specifically?
For high triglycerides, prescription-strength omega-3 fatty acids, fish oil, can lower triglycerides by up to 30%. Need the right dose, though. They do carry a small potential risk of increased bleeding. And then there are fibric acid derivatives, or fibrates, like fenofibrate. They're quite good at lowering triglycerides, sometimes up to 50%, and can raise HDL a bit. But they have a risk of muscle problems, especially if combined with a statin, so that needs careful consideration.
Are there any older drugs that are sort of falling out of favor?
Yes, things like niacin and older bile acid resins are generally not recommended as primary therapy anymore. Niacin has troublesome side effects like flushing and doesn't add as much proven cardiovascular benefit as we once thought, especially on top of a statin. Resins can be hard to take and interact with other meds. Newer options are often better tolerated and more effective.
Okay, let's focus on triglycerides or hypertriglyceridemia. You mentioned different levels.
Right. We generally categorize it. Mild is 150, 199 milli-GDL. Moderate is 200, 999. Severe is 1,000, 1999. And very severe is 2,000 or higher.
And the risks associated with those levels?
Both moderate and severe levels are clearly linked to increased risk of cardiovascular disease, heart attacks, strokes. But here's a really crucial extra point. Very severe hypertriglyceridemia, over 2,000, carries a significant additional risk for acute pancreatitis.
Pancreatitis, inflammation of the pancreas.
From high triglycerides.
Yes, it's a painful and potentially dangerous condition. So getting those very high levels down is critical, not just for heart health, but also to prevent pancreatitis. That is surprising. What usually causes such high triglycerides? Are there secondary factors?
Absolutely, and addressing these is key. Common secondary causes include poorly controlled diabetes. Getting blood sugar under control often helps triglycerides a lot. Also, untreated hypothyroidism and underactive thyroid.
Is that reversible?
Yes. Treating the thyroid condition usually improves the triglycerides. Certain medications can also raise them, some antipsychotics, high-dose steroids, estrogen pills, certain retinoids. Stopping the offending drug, if possible, often helps.
What about lifestyle?
Hugely important. Things like a diet very high in refined carbohydrates and sugars, excessive alcohol intake, being sedentary, and obesity are major drivers of high triglycerides. And the good news is, these are often reversible with lifestyle changes.
So how is it treated pharmacologically?
Well, first address any secondary causes and push lifestyle changes. If triglycerides are in that moderate range, say 199, 499, and the person has other cardiovascular risks, starting a statin is usually the main focus to lower overall cardiovascular risk. If triglycerides are 500 or higher, then besides statins and lifestyle, we actively consider adding a specific triglyceride-lowering therapy like prescription omega-3s or a fibrate, primarily to reduce that pancreatitis risk. Okay, let's pivot one more time to heart failure. How does suspicion even arise? What are the first clues?
Heart failure often presents with a sort of classic triad of symptoms, though they can be subtle initially. The main ones are dyspnea, which is shortness of breath.
Especially with activity.
Yes, or sometimes even when lying flat. Second is fatigue, a kind of persistent tiredness that isn't really relieved by rest. And third is edema, or swelling, most commonly in the ankles, legs, sometimes abdomen.
So if someone has those symptoms, what's the diagnostic process? If those symptoms raise suspicion, the next step is to look for evidence of underlying heart disease. This involves combining a few things. First, the clinical history. Have they had heart attack before? Do they have known high blood pressure, valve disease, rheumatic fever history, any palpitations?
Okay, looking for risk factors or past events.
Exactly. Then, the physical examination. Is their heart rate fast? Are the neck veins distended, increased JVP? Is the apex beat of the heart shifted? Can we hear an extra heart sound, like an S3 gallop, which often indicates fluid overload? Are there any heart murmurs? Crackles in the lungs suggesting fluid-dependent edema.
So listening and looking for physical signs.
Right, and then come the investigations. Key tests include an electrocardiogram, ECG, to check the heart's rhythm and look for signs of strain or previous damage. A chest X-ray can show if the heart is enlarged or if there's fluid in the lungs.
And the echocardiogram.
That's usually the most important diagnostic test. An echocardiogram, or echo, is an ultrasound of the heart. It shows us the heart's size, how well the chambers are pumping, especially the ejection fraction, and how the valves are working. It's crucial for confirming the diagnosis and figuring out the type of heart failure, like systolic dysfunction, where the pumping is weak, or diastolic dysfunction, where the heart muscle is stiff.
Any blood tests?
Yes, we'd check things like hemoglobin to rule out severe anemia, contributing to symptoms, blood chemistry, including kidney function, and thyroid function tests, as thyroid problems can sometimes mimic or worsen heart failure.
Once it's diagnosed, what about prevention? Can heart failure be prevented or its progression slowed?
Absolutely. Prevention is key, and it goes back to managing those underlying risk factors we've been talking about. Regular physical activity, maintaining a healthy weight, eating a heart-healthy diet low in sodium, managing blood pressure and cholesterol, treating diabetes effectively, and definitely not smoking. These lifestyle modifications and good medical management are critical.
Let's touch on cardiac murmurs briefly. They sound complex, but you mentioned they offer clues. How are they evaluated?
Murmurs are essentially sounds made by turbulent blood flow within the heart. When assessing someone with a murmur, especially a new one, you ask about key symptoms. Any chest pain, shortness of breath, palpitations, fainting spells, trouble with activity. Then, during the exam, you listen carefully with the stethoscope using the bell for lower-pitched sounds and the diaphragm for higher-pitched ones. We note where the murmur is loudest, when it occurs in the heart cycle, systolic or diastolic, its quality, harsh blowing, rumbling, and if it radiates anywhere.
And they're graded.
Yes, systolic murmurs are graded 1 through 6 for loudness, diastolic murmurs 1 through 4.
Can you give a couple of examples of common murmurs, maybe one benign and one more serious?
Sure. A very common benign one is a physiologic or innocent murmur, often grade 1 to 3, heard in early to mid-systole. It's just the sound of normal blood flow, maybe across the aortic valve. It often gets softer or disappears when the person stands up. Totally harmless, no symptoms.
Okay, that's reassuring. What about a concerning one?
Aortic stenosis. This is a narrowing of the aortic valve. It causes a harsh systolic murmur, often loudest in the base of the heart and radiating up into the neck arteries. If someone with this murmur starts experiencing dizziness or fainting, that's a very ominous sign, suggesting the stenosis is severe and significantly limiting blood flow out of the heart. Needs urgent evaluation.
Are there others worth mentioning?
Well, there's aortic sclerosis, which sounds similar to stenosis, but is just benign thickening of the valve without obstructing flow. Very common in older adults, the 50 over 50 murmur. Mitral regurgitation is a blowing systolic murmur heard best at the apex, radiating toward the armpit. It means the mitral valve is leaking backward. Mitral valve prolapse is interesting, often a mid-systolic click, followed by a late systolic murmur, sometimes described as honking. Its timing changes with maneuvers like squatting or Valsalva, which helps identify it.
This brings up something related: infective endocarditis, heart valve infections. When do people actually need antibiotics before procedures, like dental work? The advice seems to have changed.
It really has. This is a fascinating and important shift from the American Heart Association. The surprising core insight is this. Infective endocarditis is far more likely to result from bacteria getting into the bloodstream during routine daily activities like brushing your teeth, flossing, even chewing food, than from a single dental or medical procedure.
Really? Daily activities are the bigger risk?
By far. The bacteremia, the bacteria in the blood from daily life, is much more frequent, though usually transient. Because of this, the thinking evolved. Prophylactic antibiotics before a procedure likely prevent only an exceedingly small number of endocarditis cases, if any.
Okay.
And critically, the potential risks associated with antibiotics, allergic reactions, C. diff infection, antibiotic resistance, are now thought to outweigh the tiny potential benefit for most people.
So, for the average person going to the dentist?
The surprising takeaway is maintaining excellent oral hygiene every single day, brushing, flossing, regular dental checkups, is likely more important for reducing your overall risk of endocarditis than taking a dose of antibiotics before cleaning.
That's a huge shift in perspective. But are there any situations where antibiotic prophylaxis is still recommended?
Yes, absolutely. It's still considered reasonable and recommended for individuals with specific high-risk cardiac conditions where the consequences of endocarditis would be particularly severe.
Which conditions are those?
The main ones are people with prosthetic heart valves or prosthetic material used to repair a valve, anyone with a previous history of endocarditis, individuals with certain types of congenital heart disease, specifically unrepaired cyanotic disease or completely repaired defects using prosthetic material within the first 6 months after repair, or repaired defects that have residual problems near a patch or device. And finally, cardiac transplant recipients who develop problems with their heart valves, valvulopathy.
Yeah, but it's a much smaller group now.
Exactly. For these specific high-risk individuals undergoing certain dental procedures that involve manipulating gums or the root area of teeth or perforating the oral mucosa, prophylaxis is still advised.
And what's the typical regimen?
For adults, the standard is usually amoxicillin, 2 grams, taken orally about 30 to 60 minutes before the procedure. If someone is allergic to penicillin, there are alternatives like clindamycin, azithromycin, or cephalexin. Though cephalosporins generally aren't used if the allergy history involves anaphylaxis.
What an incredibly thorough deep dive today. We've covered so much ground. From really understanding the mechanics of blood pressure, that vital difference between urgency and emergency,
to navigating cholesterol and triglycerides, the power of statins, but also the other options available now.
and gaining insights into heart failure diagnosis, those murmurs, and even these surprising shifts in thinking about preventing endocarditis.
It really underscores how interconnected everything in the cardiovascular system is. And this deep dive, hopefully, provides that shortcut to being truly well-informed, giving you a much deeper, more actionable understanding than just surface-level knowledge.
Absolutely. It equips you to have better conversations with your doctor to understand your own health better.
Yeah, the details matter, and seeing how lifestyle, medication, and underlying conditions all interact is key.
So reflecting on all this interconnectedness, how our daily habits, our treatments, they all cascade. Here's a final thought. Given how much even small, consistent actions impact our long-term heart health, what's one small change you could realistically implement starting today, knowing the powerful, positive ripple effect it might have on your heart for years and decades to come?